All right. So good morning and welcome to Friday Chalk Talk. Today we have Crystal Brown. She's an assistant professor of medicine and an adjunct assistant professor of bioethics and humanities at the University of Washington. So it's a little earlier for us, and thank you. Her work focuses on the experiences of Black patients with serious illness and as they near end of life. She does Pilates every day. And side note, I'd like a chalk talk on how to accomplish that in my own life. And she is going to London to see Beyonce this summer. So take it away, Crystal.
Thank you. I'm a huge Beyonce fan. I love her so much. When I got tickets, I was like jumping up and down the hall screaming. And then I'm also going to Houston on my sister's birthday. So to Beyonce times two this summer. Thank you so much for having me. I have my 3-year-old here because there was a scheduling snafu. So I will do, we've talked about expectations, but I'm going to do my best. So I was invited to talk specifically about a specific paper, but I can't just talk about the paper without talking about my work within the larger context that I'm super excited to share with you all. Right now I'm studying all the things that our current administration cannot stand. So a lot of my work is under fire right now, actually. This is so for example, a lot of my funding actually comes from the National Institute of Minority Health and Health Disparities, which is in the crosshairs right now by our federal government. And just so you all know, I actually had an R21 that got a really great score to study sort of a branching off point of the studies I'm going to talk about here. But council was canceled and it hasn't been rescheduled yet. So that's sort of the lay of the land right now as far as um, funding and my future is concerned. But so just giving you an idea of how this is impacting some of the work that's being done. So I don't have any other real disclaimers, but I do have a positionality. I'm a biracial Black and Korean woman. This is my son when he was 1 on the left. When he turned 1, it's like a traditional Korean gathering when someone turns 1, and then my family on the right here. In the middle here, this elderly gentleman is my dad. He actually died of ALS this past summer. So the Black patients with serious illness is very personally close to me. And he was a big believer in a lot of my work. That's all of me. That's right. And my family. So I'm hoping to talk a little bit about racialized experiences, the impact of mistrust and bias in the healthcare context, specifically in serious illness, and how I use a race-conscious approach to study this and understand how some of my work might help us think a little bit about how we care for racially and socially marginalized patients with serious illness. So here's just a little bit of an overview of where I am taking you. Just to briefly talk about Black experiences in the United States in the healthcare context, what we know about disparities in serious illness, briefly talk about a race-conscious approach using a pragmatic form of critical race theory for my work, and then talk about sort of the clinician's point of view about how they have been thinking about racism and bias in healthcare, particularly when it applies to them. So really briefly, we are pretty familiar with some of the egregious historical trauma that Black patients in America have experienced, sort of most notoriously perhaps the experiments at Tuskegee University. And then this gentleman, oh, his name is escaping me right now, but he was a man in Texas who had a anoxic brain injury from cardiac arrest, and he had COVID and respiratory failure. And the doctors in Texas, he was on bi-level, I believe, for some time and didn't intubate him because they believed that his quality of life was not good. Yes. What is that? That is someone who's sick, baby otter. Um, and so they instead of intubating him, they transitioned him to comfort measures, and his family believed that yes, being a Black man was a part of their decision to not intubate him, but also that he was because of his disability of having an anoxic brain injury. And so I'm talking about this because I'm going to talk about this idea of intersectionality. So not just being Black, but what it's like to be Black and disabled, Black and unhoused, or Black and plus other some sort of socially marginalized identity. So we know that Black patients during serious illness at the end of life are more likely, in the last 6 months of life, are more likely to visit the emergency department or to be hospitalized. And when they're hospitalized, they have longer lengths of stay and are more likely to receive mechanical ventilation and CPR or to die in hospital. They're also less likely to have a DNR or to withdraw life-sustaining therapies, receive elements of palliative care, or enroll in hospice. And when enrolled in hospice, they have shorter lengths of stay. And some of my colleagues have framed this as sort of just differences in care, but I actually think this is a disparity because it means that Black patients are experiencing, as they near the end of their lives, worse quality of life, higher symptom burden, and more financial strain. So a lot of the work out there has taken sort of a colorblind approach to these disparities. For example, saying, oh, because Black people are more spiritual religious, they don't want to hear prognostic information, even though there's been some great work out of Duke that shows that that's not the case. Low levels of health literacy and mistrust. You see a prize? Okay. But mistrust has been sort of framed as this historical thing, like Black people don't trust us because of stuff that happened in the past, as opposed to things that are currently happening now in everyday interactions. There's health literacy has also been another big bad wolf. Yes. Health literacy has also been low levels, have been used to explain low implementation of advanced care planning and hospice enrollment as well. And then, of course, there's been a lot of discussion lately about healthcare worker bias, the lack of diversity in clinician workforces, and poor quality communication as well. So I'm going to talk a little bit about what springboarded me off in this direction. So I was really interested in what healthcare utilization looked like at UW Medicine when I practiced. And so the study here, the question that we asked with the team that I was working with at the time, and I would frame this differently now, is what is sort of the role of race and socioeconomic status is not well understood when we specifically talk about end-of-life healthcare utilization. And so what we wanted to do was examine this association between race and SES and healthcare intensity in the last 30 days of life with serious illness. We looked at records from 22,000 people who were cared for at UW Medicine and died within a 5-year period and linked their information to electronic health record data and Washington State death certificate data, and then used regression models and path analysis. Really briefly, what I'll say is that in some of the outcomes that we looked like, for example, CPR, there was a large sort of a direct effect between just being Black or some other racial or ethnic minority itself in receiving CPR, as well as just being admitted to any ICU in the last month of life. And I'm not going to get into these path analyses, and even if you ask me, I'm able to adequately explain it to you. And so what we said was that the effects of minority race on healthcare intensity end of life is partially mediated by social determinants of health. And then future interventions to address the other factors driving both direct and indirect effects. And when I look at this, I'm like, what does this even mean? What, like, we're thinking about a statistical, it's pink. We're looking at statistical models to try to understand this, but I think we're missing really what can't totally be captured by statistical models, which is actually trying to understand lived experiences. And so I just want to briefly tell you about Seattle and its history, even though we're in that, quote, progressive Pacific Northwest here. So this is a map of Seattle from the 1930s, sort of rating the safety of neighborhoods. So the green areas are the most safe, and then the blue areas are sort of in North Seattle are the sort of variable, and then the yellow and red areas are definitely declining or hazardous. You'll notice that the areas in pink in the map on the left are areas that are deemed hazardous. And then if you look at this map sort of around the same time, this is, quote, and this is their language here, you'll see on the map, this is, quote, where the Negroes, Jews, Orientals, and Italians live. We move to the 1960s. This has been mostly taken over by the Black population. And just to give you an idea of some of the other racialized, systemic racialized issues that have gone on in Seattle, there are neighborhoods that have deeds that in their homes that specifically say that Black people can't own this house. So where you see that on the map is all these areas in red where there are deeds that say that Black people can't own houses in these neighborhoods, and you'll see some overlap. I actually live in Capitol Hill neighborhood now, so my house or my neighborhood actually it was not one of these houses, but you can sort of see the overlap here. This also interestingly overlaps very well with clinics of where UW Medicine are located. So, so all this to say is that this is not necessarily something that statistical models, this historical racialized experiences that carry over to the current day are not necessarily going to be captured by statistical models and path analyses, but usually I think better is are actually qualitative or interviews that I'm going to share with you with patients. And so really briefly, this is the pragmatic form of critical race theory that I use. And I'm not going to get into the details now, but it's called Public Health Critical Race Praxis, has 4 focus areas and then principles of critical race theory.
This is like awesome.
Principles of critical race theory within them. But sort of within this is this idea of race consciousness, which is being aware not only of the racialized experiences and positionality of your patients or research participants, but also that of yourself as a clinician, as a researcher, etc. I'm going to skip these because I was optimistic about what I would be able to talk about. But so, okay, I'm sorry, baby otter. So taking this sort of background, I wanted to understand what it was, better understand the racialized experience of Black patients with serious illness within the medical system and how this impacts communication and decision-making. So really briefly, we created a prospective cohort of patients with serious illness who were hospitalized at Harborview Medical Center, which is the county hospital that I work in Seattle. We asked them to complete surveys measuring mistrust, discrimination, and microaggression, and performed one-on-one semi-structured interviews with a sub-cohort of them and performed thematic analysis. I'll share a little bit about what this data showed. So out of the 175 patients, actually 40% of them were Black. And the reason why I point this out is because Seattle is a very predominantly white city, and our patient population is also white. So we kind of sort of oversampled per se, but it was very difficult to recruit Black patients who were with it enough to participate in our study. And it took about 2 years to do so. They had a little bit on average, the whole demographic had a cohort had a little bit over high school level of education. They were really poor. A majority of them had household incomes of less than 25,000 a year and low levels of wealth as well. And this is a measure of assets of if they owned a house, car, had a savings account, checking account, or retirement account. And many of them were insured by Medicaid or Medicare. And so what I think is really interesting and perhaps disheartening is that out of all of these patients, so this is the participants who required experiencing discrimination, sometimes, most of the time, or always. And I don't know about you, but I think this is pretty disheartening. And these are patients who were reporting being treated with less courtesy or respect compared to other people, receiving poor service, acting as if healthcare workers are not as smart or afraid of you're not smart, or they're afraid of you or better than you, or they feel like they're not listening to you. And not everybody answered this question, but there are reasons that patients felt discriminated against, which was actually a lot of them felt like it was their educational attainment or their income that affected how they were being treated in the hospital. And then some Black patients, not all, felt like it was due to their race. And then we didn't have very many Native American participants because there just weren't very many of them, but a lot of them felt like it was also due to their ancestry as well. The other thing I want to point out here is that Black and Native American participants in particular reported there was an association specifically between experiencing discrimination as well as medical mistrust, race-based mistrust in general, in specific, I'm sorry. Here, as well as the mean scores of discriminatory experiences and the risk of also experiencing or having race-based medical mistrust as well. And so what does this mean specifically and as far as lived experiences? So we actually interviewed a subcohort of Black patients with serious illness to try to better understand what this was like for them. And so we interviewed about 25 patients, again, low levels of income, wealth, and educational attainment. And so what they shared was that they were experiencing racism in the healthcare setting. They talked about systemic racism, how healthcare is too engulfed in racism, is money-driven and controlled by racist people. They talked about personal experiences. This person talked about a resident saying, "Yeah, boss," talking to him like he's, quote, street folk. They didn't use the word intersectionality, but they talked about what it was like to be Black and poor, or being Black and having Medicaid, or being Black and in house. One patient shared, "I think there are people making decisions for poor people that should not have been made," or because of my insurance, I might not be accessing certain medical treatments. They also talked about vicarious experiences that their friends or family or people in the neighborhood went through. So this particular patient talked about a brother who didn't go to the hospital because even though he was having symptoms, and he said, my brother died of colon cancer. If he went in time, that could have been stopped. They also talked about how bad experiences in the healthcare setting informed how they communicate and make decisions as well. So some of them talked about how they limit communication to doctors and nurses that are caring for them. I don't just want to disrupt things or create a problem, even though there is a problem. Their views on life-sustaining therapies included concerns that they were worried that they were not being offered the same treatments as white patients in particular. So the medical community has a lot of things, is very strong and has a lot of things that are helping people to survive death. Those are not applied to people of color. And then struggling with this idea of trying to make sure that they got everything that they felt like they should be getting, while also trying to think about the impact on their quality of life as well. And then lastly, I'll talk about epistemic injustice or mistrust. And so epistemic injustice is this philosophical term that's, it sounds very esoteric, but I think the idea is actually very familiar to us. It's simply when a healthcare worker does not take seriously what a patient is saying because of some feature of their social identity. And so patients talked about dismissal. Well, this is my body, I'm going through it, but feeling like there's a God complex. This idea coined by W.B. Du Bois of double consciousness, which is this idea that you're aware, it's sort of like hypervigilance. You're aware of how you are being viewed by your doctor or nurse. I can tell if doctors are looking down their nose at me. And the vulnerability that results from this. So there was a patient that talked about how the triage hospitalist didn't believe his symptoms and tried to send him home. And then he shared, I woke up in the MICU. I asked, where am I? The bedside nurse shared, you're in the MICU, your blood pressure bottomed out, the tears rolled up. I thought about that doctor telling me to go home. They talked about the lack of trust this resulted in. One patient who was admitted on the cardiologist service said, I don't see a person that puts energy into being racist coming to conclusions that are medically good. So when we talk about serious illness communication, we really hope that we're talking to patients and families about values or preferences without concern of controlling influences. And oftentimes what we mean by this is medical urgency as the controlling influence. So let's talk about this and make a decision before you get too sick. But what I would say is that some patients are experiencing that the controlling influence might actually be things like stereotype threat, being worried about being like the angry Black man or angry Black woman, hypervigilance, this idea of multiple consciousness, being aware of how you're being viewed and feeling like your voice is being silenced every day and everyday interactions. And so I would say that these values and preferences or how people make decisions might be be born out of these unequal power relationships. Okay. So really quickly, I just want to say that I've interviewed clinicians about how they navigate these situations. And what I will say really briefly is we use scenarios to interview clinicians. And we offered scenarios because we didn't want to force people to disclose things that they were embarrassed about or didn't want to or felt like they did something wrong. And so the first scenario was a Black man who felt like their pain was being undertreated. And the second was a patient who felt like, and these were actually scenarios out of patient interviews. Another patient who felt like repeated discussions about code status was because she used substances and felt like the doctors and nurses weren't agreeing with what she said, and it was sort of like a questioning her decisions. So we interviewed about, I think, 21 medical subspecialists. And what they talked about was this need to improve communication, to better understand patients' values and goals, and sort of hammering them when we felt like we weren't agreeing with their decisions. They wanted to know if they were causing distress or felt like felt like we were giving them discriminate care. And then also time and space to process defensive behavior or hard to hear news about their care away from patients and families. They felt like there wasn't a framework or any kind of language to help them talk about these things. So clinicians often felt like they were going to step on a landmine and say something wrong, even though they knew that this was an issue. They talked about how some of their colleagues might need data to say, oh, perhaps I am providing disparate care, and help them pause to think about or reflect on that, which I feel a certain type of way about. But and then this need for receptiveness and humility. And as well in the training environment about how do you give feedback to residents and fellows when when they've gotten um, news that the resident, for example, was speaking inappropriately to a patient. How do we do that? So they felt like they couldn't talk about to have these conversations with patients, but they felt like they needed to be the ones to talk to medical learners. And then lastly, they felt like patients should feel empowered to say what they're saying, recognizing that there's this really stark power imbalance between being a patient and being and in a hospital gown, laying in a bed, and then talking to doctors in white coats, having a set of questions that perhaps patients could use that felt safe, sort of like, why are you asking me that question? When they felt like when they felt like clinicians were asking them um, questions that they felt were discriminatory, and then having more safe space for advocates. So really, there's like this tension between patient and provider needs. Yes, ma'am. Done. I'll be done very soon, okay? This unawareness or appeasement of concerns that occurs, defensiveness, a lack of framework or language to use to talk about these concerns, as well as this need for data to be receptive to them. And then on the patient and family side, we have these unequal power dynamics up, as well as lack of workforce representation and intersectionality. So physicians are ill-equipped and unprepared. Patients and clinicians could both benefit from coaching and support, and that would look different depending on who you're talking to. A lot of clinicians said, Black patients, especially ones who are seriously ill, shouldn't have the burden of calling out racism or discriminatory behavior. But you know what? I don't want to be the one to do it. So I'm not sure who's actually going to bring up these concerns. Perhaps this is where an advocate can help. And then clinicians are saying repeatedly that they wanted help managing the defensiveness that comes with hearing this feedback. So I am going to stop here and just say thank you to some of my mentors here. Bessie Young's currently my mentor, Randy Curtis, who died 2 years ago, also from ALS, was my mentor for many, many years, as well as Abby Rosenberg and Sharita Golden. And then Ray Marshall here is the research coordinator who helped me do the interviews and the surveys. Really indebted to her. She's over in Yale, moving on with her life. I miss her dearly. And then also this team of collaborators that I have as well. Yes, I know, and you're there too. So I will stop. That was a lot. If you want to help me out and provide feedback, that would be great. There's a QR code here, and I will be happy to answer questions. I know we haven't left a lot. I had a lot I wanted to share, but I'll stop there.
I'm really grateful for your time, and I echoes Marty's statement in the chat. But talking about this very challenging and serious subject while also parenting a 3-year-old baby otter is amazing. And I'm really, really grateful for your time today and for everything you've shared with us. Do we have any questions for Crystal? Marty, you have a question for Crystal.
Yeah, my question kind of comes to framework. I'm sure it is a talk in itself about how do we address, name the elephants in the room, talk about some of these things. Can you give us even a little pearl of wisdom about how you, I don't know, even begin to ask about some of these topics?
You're talking about as far as research is concerned, like the interviews or?
Oh, sorry. No,
Oh.
I mean, like, let's say you come into a room and you're seeing a lot of anger and you're worried that something like race is playing a role. How do you start to ask that with curiosity and compassion?
I feel like a lot of it actually is just something that a lot of us don't have time for, which is time. A lot of us don't have time for time. And building rapport. And so I'm sorry, what some of the patients said was they started to feel more comfortable when when they saw team members come back repeatedly. So, you know, sometimes we round and then we leave and then they're like, and then I don't see them for the rest of the day. But there was one particular patient who talked about, I'm sorry, how much she loved her rheumatology consult team. And that was a team that she was able to connect with because there were people that came back. I think they had the benefit of like having a medical student or someone else who was able to provide some additional time or continuity of care that perhaps the attending wasn't able to. But I think people really open up once you have invested time and a rapport with them, as opposed to trying to ask them right away. So I think if you sense that that might be an issue, I think that's a cue to you to try to invest a little more time if you have it.
Thank you.
Sorry.
I was struck, I don't even know if I necessarily have a question tied to this, but I was struck when you talked about that our patients may have values born out of an unequal power relationship. And like this has become part of their decision making, and it drives it drives many sometimes of their healthcare decisions. And like the tension between wanting them to receive the best possible care, which sometimes seems like not doing all of the things, but also understanding that they are valuing getting everything because they felt like they have not had access to those things in the past. And that's come up in several of my patient conversations this year. And so hearing that from your presentation as well was very validating. I'm not really sure exactly where to go with it other than really understanding that value, naming it, and just really trying to acknowledge it in our conversations, and show that I respect that that's what they're choosing to, prioritize and emphasize in their care. I don't know if you have any other thoughts.
Yeah, it reminds me of a talk I went to by Autumn Feaster. It was like more about mediation. Hey, Kat, I'm just gonna say one more thing, okay? Okay, hang in there, baby otter. My son goes by Baby Otter. And by Autumn Feaster, who's over at Penn, who talks about mediation. And I think oftentimes in those situations, the care team and patients want the same thing, but the values are different, right? So like they talk about the roots in the trees being the values, and then the tree branches being the actions or decisions people make. And so I think if people could recognize what those values and beliefs are about mistrust or feeling like you've been getting disparate care, maybe even all your life, and seeing the same things happen to other people in your community, you can understand why patients or families might make the decisions that they do. What we see as like the branches without really understanding the roots that are in the ground that drives those decisions. So I actually give a talk on like moral distress in the ICU and use that tree, the two different trees, okay, as a to the residents. I'm sorry.
It's
And
okay.
I think it's helpful. I think it's helpful, but take and sort of mitigate some of the moral distress that that residents have, but maybe perhaps not all of it. But I think it helps people better understand it once we think about the tree.
Yeah.
Yeah.
Thank you for your time. Please take care of your baby otter and thank him for his time as well. It's made it absolutely delightful, and good luck to you with your research. It's very important.
Thank you so much. And thank you again for inviting me. This was like truly a delight. And I'm so happy to share my work with you all. Thank you. Okay,
Thank
we're
you.
all gonna say bye, baby otter. Bye.